Can everybody hear me okay here? Okay. There's nothing on the screen next to the side of the, you said that it would be there. I can get it. I can walk to the side if I need to. Yes, so I was invited back, and I appreciate that. And I was specifically kind of asked to do this lecture again on dementia. It is one of the more needed topics, I think, and there's a lot of things that can probably be caught that maybe you didn't hear before. If you've already heard this lecture, thank you so much. The other thing is I did update it a little bit and rearrange some things, and also the questions at the end are probably one of the most important things to me, because I want to make sure that you guys have your questions answered and you feel comfortable treating these patients as first line providers to them before they end up coming to a geriatric psychiatrist or just a general psychiatrist. So I will try to make time at the end for that. Okay, so this is kind of what he already said, so I'm not going to spend a lot of time on that. But I did move to Vanderbilt recently, so now I'm starting to expand their geriatric psych inpatient program, as well as move into facilities, long-term care, like assisted living and nursing homes. So that's kind of my area. So I have no disclosures, but I always pretty much talk about medications off-label, because there really aren't that many on-label for dementia. So we kind of have to do what we have. So my objectives are going to be just recognizing the symptoms of dementia with behavioral disturbance, utilizing evidence-based treatments for them, and then understanding the risk benefits. When we do use these pharmacologic interventions, what do we need to watch for in elderly, because it is slightly different and you have higher risks of all medications. So dementia in general is a decline in mental ability that is severe enough to cause problems in their everyday life. There's lots of other definitions you can find for it, because dementia is a very broad topic. It has lots of different subtypes, but you can see here people will describe it just as a group of symptoms of some type of decline in memory. Specifically, when you look at areas, it's memory, language, attention, concentration, executive function. And then now you'll also see the term major neurocognitive disorder, because that is the new DSM-5 diagnosis. And then at the end of it, you just kind of say what type it is: Alzheimer's, vascular dementia, Lewy body, whatever it is. You just put that on the end, with or without behavioral disturbance. So dementia is extremely common. As we know, with the baby boomers coming of age, there's a growing population that are developing dementia. It affects more than 5 million people. About 13% of Americans over 65 have some type of dementia, and then the prevalence of cognitive impairment is about 16%, so it's a little higher. Also, people around 80 years of age, they have about a 50% chance of having some kind of cognitive impairment. So if you see a patient that's 80, you're most likely going to start noticing some symptoms in about half of them. And then about almost 1 of every 3 patients 65 and older have some type of mild cognitive impairment. So it is very complex. Our elderly patients don't just have one thing wrong with them. So they've got a lot of things going on. The behavioral symptoms are usually what cause the patients to go into a long-term care setting. We always want to try to keep them as independent as possible and stay home as long as possible safely. But that is the biggest stressor for their caregivers and what forces them into nursing homes and other long-term care settings. So I know a lot of you are primary care physicians, and so you guys are our first line for recognizing any cognitive impairment and dementia, and also treating it, because the sad fact is there's not enough geriatric psychiatrists to see all of the patients with behavioral symptoms of dementia. So whenever we're talking about what these are, what the neuropsychiatric symptoms are, this is kind of what we're talking about. So the classic ones that everyone thinks of is wandering, repetitive behaviors, exit seeking, but then also the mood symptoms, anxiety, depression, apathy is a big one that people a lot of times miss. So that is kind of it's got similar symptoms of depression, but it's more of the lack of motivation, lack of emotion, and they just kind of say they're okay sitting on the couch for hours and hours and hours and just not doing anything. Those are all symptoms that we would consider behavioral changes in dementia too. You'll also see changes in appetite and sleep. Sleep is one of the huge ones that affects the caregivers. If they're not getting sleep at night, then they are going to get burnt out. It's the same way as kind of, not sleeping when you have a small child. You're up like every few hours during the night sometimes because they're trying to wander off, and that is extremely stressful for the caregivers. And then later on in the disease process, you'll see more disinhibition, aggression, hallucinations, and delusions. So how common are these behavioral disturbances? Well, in about 43% of patients with mild cognitive impairment have not even been diagnosed with dementia yet. They already are starting to have some type of behavioral disturbance. In fact, there's been studies that have started to come out now that have shown that behavioral disturbances start to show up, like anxiety, depression, or apathy, up to 2 years in advance of the memory impairment. So you can actually start to see these behavioral changes and then say, hey, new onset anxiety in an 80-year-old, probably not super common. Unless there's a specific stressor that's causing it, you need to start thinking, oh, there could be some organic change that may be causing this new onset anxiety. And then up to 90% of all patients with dementia will have some type of behavioral disturbance in their course of their illness. So almost everybody. So if you're not sure if there's a behavioral disturbance, there are some scales that can help. The PHQ-2 or PHQ-9 can help with depression symptoms. And then the neuropsychiatric inventory, there is a brief version of this that can go through all psychiatric symptoms pretty much to give you an idea if the patient recognizes any of them, or later on in dementia, you can also give it to the caregivers and have them fill it out, and they can tell you kind of what they're seeing. So the treatment for these behavioral disturbances. So we want to always make sure there's no underlying medical conditions. Rule out delirium, basically. Make sure there's nothing going on, or reversible causes of dementia. So we'll talk about that. Then once you realize, okay, this is probably their dementia, then you want to look at non-pharmacologic interventions and then move on to the pharmacologic interventions later. So for a medical assessment, like I said, we're ruling out delirium. So we're looking for reversible causes of their cognitive impairment or their change in their behaviors. So you get a whole variety of labs, making sure there's no infection, electrolyte abnormalities, any problems with their liver, or like a hyperammonemia. Syphilis is actually on the rise in all populations, but it can be in geriatric population too, because they don't have the concern of becoming pregnant, so they don't always use protection. B12 folate, so you can have vitamin deficiencies. The UA, of course, is one of our biggies for delirium. If you have any UTI, it completely throws them for a loop. And one thing that I do see sometimes is people will look at the UA and be like, oh, it's just mildly positive. Mildly positive or severely positive, it can still throw them into a complete delirium. So keep that in mind, that it doesn't always mean the severity of the UTI can still cause a delirium. And then a urine drug screen, I know it seems a little bit silly or kind of demeaning to them to get a UDS in a geriatric population, but they still do use drugs a lot of times. Some of them grew up in the 60s and 70s, so this is just part of their normal life. But one of my attendings actually had a little old lady that was growing a pot plant in her nursing home room. So it does happen. She had a little lamp in there and everything. It was great. So, but then I have also had 60-year-olds that were still using meth. So I'm shocked that they have been able to survive that long using meth, but it is possible now. We take great care of our people that use substances now. So they live a lot longer. So keep that in mind. And then if there's any concern for some type of brain lesion or, concussion, head injury, you can also get a CT or an MRI to rule out any reversible causes, also NPH if you're concerned of normal pressure hydrocephalus. And then the last one to look at for medical causes is you want to always review their medications and make sure that you don't have any high-risk medications, and we'll talk about those next. So there's the whole huge beers list that you can look at, and that basically, in my opinion, tells you don't use medications in geriatrics, which is extremely hard, obviously, because everything has a contraindication almost in geriatrics. So what I tell people to focus on is the anticholinergic medications. That is absolutely number one, because I have seen even hydroxyzine or Benadryl, something like that, throw someone into a complete delirium, and they were taking it for sleep, Tylenol PM, because they don't realize that it has Benadryl in it, and they end up in the hospital for like a week because they're completely out of it. So make sure that you're watching for anticholinergic medications. The next one, not necessarily in any order, but the antipsychotics, we always try to use the lowest dose of these medications because they do have side effects. Benzodiazepines, a huge no-no in my book because there are almost no studies that show that benzodiazepines are helpful. The only time I use them is in patients that urgently or emergently need medical attention and they need to be calm. But other than that, do not use the benzodiazepines because it has a lot of risks, and you're more likely to cause a worsening delirium than you are to actually improve it. So we'll talk about that a little bit more too. And then the last one is opiates, which I'm not saying you cannot use opiates in the elderly because they obviously have a lot of chronic pain from arthritis and other things that have happened to them throughout their lifetime. But we always want to use the lowest effective dose because the higher you are in the dose, the more likely you are to get a delirium. And then they just take that medicine over and over every day, and so they stay in this constant state of delirium due to their opiates. Okay. So non-pharmacologic interventions, I've said this is first line. This is the mainstay that everyone will talk to you about using before medications. So I like to expound a little bit on what that is. What is a non-pharmacologic intervention? So we're talking about environmental changes, any assistive devices, or task simplification to reduce the frustration of some of the things they may be struggling with. Getting physical therapy, occupational therapy, or speech therapy involved can be a huge help because they are used to looking at these things and using the assistive devices, and they can also think outside the box pretty well. So keep that in mind, that bring in additional help if you're seeing some of these things. Some of the occupational therapists even have specific programs for cognitive deficits, and they will go through different tasks and things to help them. Speech therapy does that as well. Social services, so education, support, and resources, not only for the patient in the earlier stages, but for the caregivers later on. That way the caregivers understand what the symptoms are, what they're looking at, and how best to deal with them. Because they don't understand why their mom is acting the way that she is anymore. That's not their mom. It's very difficult for them to understand that this is the illness that they're looking at. And so helping educate them about that can also reduce the burden of the behavioral disturbances because they're not getting as frustrated at the patient. And then psychosocial practices. So talking to the patient about their illness and understanding their symptoms and why they're frustrated is very good. Reminiscence therapy can be helpful because they like to talk about all the things they've done throughout their life. Music therapy, pet therapy, and meaningful activities is a huge one to me because there isn't a person in this world that doesn't want a purpose. So if you give them something to do, that will make them so much happier. And it's something as simple as just, doing an activity there at the assisted living that helps other people. Or even whenever they're, more demented, it might be folding towels or holding a baby. That is purposeful activities to them that is important because they may still have that motherly instinct, or some of the men may want to work with tools still or something. So you try to give them a safe, obviously, option to be able to do some of those things. But you want to make sure it is personalized and you don't just randomly give someone something that they have no interest in. You want to know what it is that they did for a living, what kind of hobbies they have, and then try to best meet that. Obviously, it can be a little concerning giving a patient with aggression and dementia a golf club if they're interested in golf, but I have done a putting green inside of a nursing facility, and it worked really well. He enjoyed it. He did the putting every couple week or every time, or excuse me, a couple days a week, he would do putting on the little putting green. So you just have to monitor them with it and just make sure that, they aren't beating someone over the head with a golf club. But it usually works pretty well. Okay, excuse me. The other thing, as the disease progresses a little farther too, you can use things like aromatherapy, massage. I had a person that worked at a behavioral unit that did hand massages for the patients, and they absolutely loved it. They would just completely relax whenever you would do the hand massage for them. Multisensory stimulation, so they have multisensory blankets, other things like that. And then bright light therapy has shown some benefit. And actually, one of the facilities I'm moving into with Vanderbilt has bright light tables throughout their facility. The hardest part of that is just keeping them kind of engaged at that one location because they want to obviously wander and move around. But if you have something there that's interesting, they'll stay there a little bit.
What kind of bright light is it?
So it's just literally a table that has a light underneath it that shoots, that kind of just... I'm not sure what type of light they have in it, but it's just a white light that they've got at their place. But there's different levels. There are different levels of light that you can get for those tables too. Okay, so caregivers, we've already talked about this a little bit, but the caregivers, you need to identify who that person actually is because it might surprise you. It's not always the son or daughter. It could sometimes be the neighbor or an aunt or something like that. You want to identify who the person is that takes care of the patient the majority of the time. Make sure that they understand the disease process and try to help educate them. And then help them with whatever it is that they feel is the biggest problem that's causing them stress. There is a caregiver burden scale, which can also help you determine how burnt out they are, because you definitely do not want them to be completely burnt out where they start struggling and then that causes the patient to struggle. So you have to tell them they need to spend time taking care of themselves. You need to get respite care or something to allow them a break so they can actually do some of the things they like to do as well. So here's some resources for caregiver supports, lots of different ones, and they have links within their websites that you can get to as well. So safety concerns is always a big issue, especially in the primary care when you're seeing someone outpatient. Driving evaluations can be helpful. The DMV does driving evaluations. You can also do the TRAILS A and B test to give you an idea of where they may be on their executive functioning, and it's one of the best tests to tell you if someone is able to drive still. And then actually the clock draw is also really a pretty good indicator of how well someone would do with a higher level processing thing like driving. Level of supervision, again, this is the patient safe to be at home with maybe just one caregiver that's still going to work? Or are they wandering off or taking medications when they're not supposed to be doing? And then, unfortunately, elder abuse and neglect is something you have to keep in mind too, because we do see especially financial abuse of the elderly quite frequently. So, pharmacologic treatment. This is the next section that I know a lot of people are waiting for, but I want to stress again, first line is non-pharmacologic. So think back again about all those things we just talked about before you start prescribing medications. So there are not very many dementia-specific medications, but I always like to talk about those first because that's actually what's FDA approved. So we have the memory medications with Aricept, Exelon, and Razidine. So these are for the cognitive symptoms of dementia. They do not slow the process of dementia, and I always make it very clear to the patient and their family that this does not stop the progression of the disease. It does not slow the progression of the disease. The goal of it is to maintain their current functioning at their level right now as long as possible. Eventually, the disease will overtake the medication, but there have been studies that show the quality of life and their ability to perform daily activities stays longer when they're on these medications. The actual cognitive improvement that you see is like 1 point on a mini mental. That is not good. So don't look for a huge improvement in cognition, but just monitor their functioning long term. So Aricept and Exelon and galantamine are for mild to moderate dementia. So you'll use these first line. The most common one's Aricept, just because of the ease of use, and it has slightly less GI upset than the rivastigmine. So you'll start 5 milligrams at night and then increase to 10 milligrams after 4 to 6 weeks. I normally do not go over 10 milligrams because the GI upset becomes worse to the point where they don't end up tolerating the medication, and then they have problems like poor appetite, and it causes more problems than it helps with. So one of the reasons why I'll use Exelon or rivastigmine instead of Aricept is specifically in patients with Parkinsonian symptoms, so Parkinson's disease, Lewy body dementia, supranuclear palsy, or frontal temporal dementia also. It seems to have a little bit better benefit for some of the behavioral symptoms in those diseases as well as the cognition. So we usually try to use the patch. Sometimes insurance will push back on that, but the oral version of Exelon is usually not well tolerated, and you'll end up getting a lot of upset stomach. And then the last one is galantamine. You really don't see this one used that much just because it's a BID dosing, so it's a little bit harder. And then it was the last one approved too, so it's just not used as much. Okay, then after you've reached the moderate to severe stages of dementia, you've got Namenda, or Namzaric, which is just the combination of Namenda and Aricept. So the other ones were acetylcholinesterase inhibitors. This is a glutamate antagonist, and this is basically the last line that we have for memory. So once their impairment is worsened to the moderate to severe stages, you can add this. It's very well tolerated, I will say that. So sometimes with patients that don't tolerate Aricept, I'll go ahead and start Namenda a little bit earlier sometimes, just because it is more tolerated than the Aricept. But you do 5 milligrams daily, and you increase by 5 milligrams per week up to 10 milligrams BID. And then the Namzaric has a fancy, expensive starter pack you can use too. Okay, so like I said before, the goal is to maintain functioning as long as possible. There is good evidence that shows they have a benefit on behaviors. It's not like super amazing for like psychotic symptoms, of course, but a lot of the general concentration, irritability, anxiety type symptoms, you will see a benefit from because it helps with concentration as well as just maintaining the function. So when they're able to concentrate a little bit better, that can help with their frustration tolerance. So one of the biggest questions I get on this is, when do I stop it though? When do I look at this and say this is no more benefit for the patient? So the biggest thing is whenever you see no benefit but you're seeing side effects, that's when you'd stop it, obviously, because if you're not going to see a huge benefit most of the time, you just notice that they don't decline as quickly with their functioning. But you're not going to see a huge on-off effect from the medication. If they have a very rapid decline within 6 months, you start to say, okay, I don't think the medicine's doing much anymore, let's try to get rid of it. And then if the severity of dementia is so profound that they have little to no functioning left to preserve, so if they're no longer walking, talking, eating, or like feeding themselves, if they're not doing any of that, then the medication's not beneficial anymore. But usually I leave it on for as long as possible, just because I want them to maintain their independence and functioning for as long as possible. So then if you move outside of the realm of the actual FDA-approved medications, you start looking into other options. So antidepressants have actually been found to be extremely effective for dementia with behavioral disturbances, and not just for anxiety and depression, but actually for the psychosis as well. And the reason for that, we believe, is that it's a type of like anxious delusion, kind of a misinterpretation delusion related to their memory impairment. So they may think, oh, my kids are outside and I have to take them to school. Well, yes, that's technically a delusion, but it's not out of the realm of normal things. If they were back 30 years ago or whatever, they may have had kids that had to go to school. So you have to keep that in mind. They're not actively saying that someone's poisoning me. They just believe that their kids are much younger than they really are because of their cognitive impairment. So whenever they get very anxious and restless like that, that's when the antidepressants can be very effective in treating those types of misinterpretation delusions. So there was actually a study called the CATIE-AD trial that looked at antipsychotics and Celexa, and found that the Celexa was as beneficial as the antipsychotics for the dementia with behavioral disturbance. So that is pretty impressive considering the side effect profile for Celexa is way less. So we want to consider these kind of as our go-to medications once the cognitive medications are no longer providing significant benefit. The ones that we found the most benefit with are Zoloft, Celexa, and Lexapro. Those are very calming medications. The only issue with the Celexa is you cannot go over 20 milligrams because of a black box warning that causes QTC prolongation. It's only about 10 milliseconds, but you still have to keep that in mind. And now Lexapro has started adding that same black box warning over 10. So you kind of just have to keep an eye on it. But I usually don't go above 10 anyway with Lexapro because there's very little benefit of over 10 milligrams in elderly anyway. So I still typically will use the sertraline or escitalopram. Okay. Next one is sleep aids. So like I said, sleep is a huge stressor for the caregivers, so you need to be able to get a good sleep pattern. Melatonin can help with the circadian rhythm disturbance, the sleep reversal. It can help with that if you give it about 2 hours before they want to go to bed. It will help them kind of slow down a little bit and go to sleep. The main thing I want you to take away on the melatonin, though, is there's really not much of a benefit over 3 milligrams for insomnia. That is pretty much it, but you'll see people taking 10, 20 milligrams because in the American way, more is better, right? So they just start taking as much as they can, but it just literally doesn't do anything. It doesn't necessarily hurt them either because there's no negative feedback in the brain that stops like endogenous production of melatonin. It just doesn't do anything though. The only time I will go over 3 milligrams is if I have someone with REM sleep behavioral disturbance, and then you can go up to 10 milligrams. That is the only time I will go over 3 though. Then the next thing I use is trazodone. I really like this medication in the elderly because it is pretty safe, and it can be used in sundowning, which is very common, where they start to get more confused as the night goes on. Most of that, we believe, is due to overstimulation throughout the day, and they just get overwhelmed, kind of like if you think of a toddler that gets too overwhelmed and needs a nap. So I know I don't want to demean the patients, but that's basically what we're looking at. And if they take a nap, sometimes it will actually reverse the sundowning symptoms. But most of the patients don't want to lay down and take a nap in the middle of the day if they're already up and moving. So what I will do is add a dose of trazodone. If it's just around 8 o'clock at night when they start sundowning, you can just add it to the time that they want to go to bed. But if they have sundowning symptoms as early as like 3 p.m., which is somewhat common, 3 to 5 is when it starts, you can add a 25 milligram dose of trazodone around the start of the symptoms, and then add a 50 milligram dose whenever they're ready to go to bed. It doesn't cause significant sedation. It just allows them to tolerate the stimulation for the rest of the day and relaxes them just a little bit to where they're able to not get ramped up, and they just kind of slowly get more relaxed and go to sleep whenever you give them the second pill. I do not give it earlier than 2 because then you're just starting to look at just sedating the patient during the day, and I try not to do that. So if it's earlier than 2, I really push for trying to get the patient to go down for a midday nap after lunch, which is usually pretty easy to do after they eat because they're usually kind of interested in taking a nap anyway. So that's one of my go-tos for sleep. And then Remeron is another good one for sleep, especially if it is a small, frail person that needs to eat. The Remeron can help with appetite at lower doses. It's best for sleep and appetite. And then if they also have more depressed mood symptoms, you can add it at 15, 30, and 45, and those are going to be more for depression. The 15 milligrams is usually the most beneficial for all of them, so I kind of start there and then adjust as needed up or down. And then the last one that is really safe in elderly is Belsomra, so Suvorexant, and there's a couple new ones that have come out, basically the exact same thing, but of course they always like to rebrand. And they are safe and effective in patients with dementia. And the main side effects were somnolence, which that's kind of what we're going for, and the other thing was headache, which is pretty mild from a sleep aid. So this is a really good drug, but it is expensive. We're looking at like $400 a month. So it can be a bit difficult for them to get that. But obviously, if they failed multiple other medications and they're just grasping at straws, that can be something you use, and you can also try to get some assistance from the pharmaceutical company sometimes. Okay, benzos and Z drugs. I told you we'd talk about this again. So there is not a recommendation for benzos. If you show me one article that says, yes, use them, I can probably show you about 50 that say, do not use these medications in the elderly, especially elderly with dementia. They increase risks of delirium, disinhibition, falls, just confusion overall. And obviously the sedation is a concern too. So this is something we definitely do not want to use. One of the reactions that I always talk about is the disinhibited reaction. These medications are basically alcohol in a pill form. So you're giving grandma a shot of tequila every time you give her one of these Ativans. And if you think about what people do whenever they take a lot of shots of tequila, they get very disinhibited. They act kind of like college kids, and they start doing things that they shouldn't do, like strip naked and run through the nursing home. And I've seen it happen multiple times, and I ask, are they on Ativan? And they usually are. So please keep that in mind. And of course, the risk of falls is huge because if a patient with dementia falls and breaks a hip, their mortality shoots through the roof. So please do not use these medications. And the Z drugs are basically just as bad, so we try to avoid them as well. Anticonvulsants, I do use these occasionally, but I would recommend probably most of you not using them because there's not a huge amount of evidence, and the amount of patients that are actually benefited are a very small amount with specific symptoms. So in general, we say don't use them because the evidence is so variable. Some will say Depakote is neuroprotective and it's great for dementia with behavior disturbances, and then other ones say nope, it's neurotoxic and it's actually making their symptoms worse. So just keep that in mind that there's not a great anticonvulsant. So the antipsychotics, if you can, if we are around, refer to a geriatric psychiatrist, even a regular psychiatrist that is comfortable managing antipsychotic medications. But the main point I want to make is please only consider these if there are actual hallucinations, seeing or hearing things that are not there, true paranoid delusions like saying people are trying to kill me, people are poisoning my food, or physical aggression where they've actually, started to not just verbally threat, but actually do things to hurt people. Those are the only times that I try to use those medications, because otherwise you can usually treat their symptoms with the cognitive medications and the antidepressants. So a couple other important things is there is no significant benefit of the typical antipsychotics versus the atypical antipsychotics. So we really avoid using the old typicals because the side effects are much higher and they don't necessarily work better than the atypical, excuse me. And then there's only modest evidence, even with the atypicals, that their dementia with behavior disturbances improves. A lot of it is some sedation more than anything. So you have to keep that in mind too. The three that are used in dementia with behavior disturbance is risperidol, olanzapine, and quetiapine. So risperidol and Zyprexa were found to be effective in that CATIE-AD trial, with the least amount of side effects being risperidol. Then olanzapine was the next, but it had a little bit more increase in sedation. And then later on, another study was found that quetiapine, Seroquel, was also found as effective as Zyprexa. So those are the only three pretty much that we should be using in geriatric patients with dementia. There is a black box warning, so be aware of it, that there is increased morbidity and mortality with patients with dementia-related psychosis. It is an increase in death that people will say, oh my gosh, you're going to put her on this, or you're going to put my parent on this. And it looks really bad when you look at it because it's twofold, but the percentages are still very small. And I think I've only seen probably one or two where I definitively said, yeah, that was probably the antipsychotic that caused that side effect that caused their death. So it is not super common, but it is something to keep in mind. One of the biggest things that I see with patients is they're overly sedated, so then they end up getting a respiratory infection, and that's what kills them, is they get pneumonia because they're on too many sedating medicines. So for dosing of these medications, what I will say is a good general rule is to use 1/4 of what you would use for schizophrenia. So if you look up in Hippocrates and say, oh, it says start risperidol 1 milligram, no, that's for schizophrenia. So you want to start the 1/4 dose for dementia with behavioral disturbance. You want to start at 0.25. It sounds like a tiny dose, but that's because their metabolism doesn't work as well, and we're not treating true schizophrenia, we're treating something different. So please keep that in mind. The maximum is also 1/4 of what you would try to look at in dementia, or excuse me, in schizophrenia. So I usually say with risperidol though, the maximum is 1 milligram. Technically you can go to 2 milligrams, but I try not to go over 1, because if you're not seeing significant benefit at 1 milligram, it's usually not going to work. Then with Zyprexa, you start at 2.5 and the maximum is 10. And then Seroquel, you start at 25 and you can go up to 200. Risperidol and Zyprexa, you can usually do once a day. Sometimes you can do risperidol twice a day, but Seroquel, you do usually have to dose twice a day. The Seroquel, another point on this one is, please do not use this as a primary sleep aid. It is not a sleep aid. It's sedating the patient, but yes, they're going to sleep, but it's not a good sleep. It's a drugged sleep. So please try to use those other options first for a sleep aid. And then, if they need to do like a sleep study or something like that, that can also be very beneficial. But Seroquel should only be used still if they are delusional and aggressive and they're having problems with sleep. Like, that's a little more understanding. But try the trazodone cocktail first that I was explaining earlier, and then if you have to, go to the Seroquel. But I try not to use it just for that. And then the last one is Nuplazid. So I didn't talk about this one in the CATIE-AD trial because it didn't exist at the time. And it is specific only to Parkinson's disease. So it is one of the other FDA-approved medications for Parkinson's-related psychosis. It works in a totally different mechanism of action. It does not work on dopamine. It works on serotonin. So whenever you're thinking about Nuplazid, I want you to think of an SSRI type effect. it takes 4 to 6 weeks for this to be very effective. So you're not going to give this and they're immediately going to get better, like if you gave someone the Seroquel or whatever. That does not mean don't use it, because it's actually very effective. Whenever I get this and am able to give it to a patient with Parkinson's disease psychosis, it's probably 80% effective, which is huge for any psychiatric medication, honestly. But I have seen it be very effective, and it's not very sedating compared to the other ones. So it is expensive, but you can usually get it much cheaper through the pharmaceutical program. And I do find it very beneficial. It's not great in the acute setting, obviously, because it takes 4 to 6 weeks. But it's also easy to dose because it's 34 milligrams, and that's it. So I think that's pretty much, the only other thing I would say is with Parkinson's disease or Parkinsonian symptoms in any patient, try not to use the Risperdal or Zyprexa. You want to stick to the Nuplazid or Seroquel because they have less extrapyramidal symptoms, so less of the stiffness and all of that with patients with Parkinson's disease or Parkinsonian symptoms. Okay, so I'm going to go through some of these cases, and then we're going to have questions at the end, hopefully. I don't know how much time I have left. So this first case is Restless Regina. She's 79. She lives at home, and the husband states she is constantly moving, just picking at things, going through things in the house, repeatedly asking about their children, becoming agitated if you dismiss her. So you always have to continuously validate her. And he's just saying, this is getting exhausting. I can't keep doing this. So this is the example of the kind of anxious delusions about the children, their misinterpretation because of the cognitive impairment. And you would want to try to start an SSRI to help with some of those symptoms. So you would start Lexapro 5 milligrams daily, and then if tolerated, it can go up to 10 milligrams in about a week. It's usually very, very effective. Next one is Sleepless Sally. So a 90-year-old female is living in an assisted living memory care unit. The family states that she is great during the day. She's just like our mom, but then at night she becomes a totally different person. She's very agitated, exit-seeking, and verbally aggressive. So they're asking, what can we possibly do to help her get some sleep and to calm down in the afternoons? So this is whenever you would use my trazodone that I really like. If it's just at night, again, you can use the 25 milligram or increase to 50 if needed for sleep. And if it's earlier in the day, though, you can give that 25 milligram dose a little earlier and then the 50 milligram at night. Lazy Larry. So this is a very common one, unfortunately, that I hear, is the patient is sitting at home in his chair all day long, just watching TV, doing absolutely nothing, won't even get up to do his ADL care. He's not showering, bathing or brushing his teeth. And so the son comes in and says he must be extremely depressed. He just doesn't care about anything in life anymore. And you ask the patient how he's doing, and he says, I'm good, everything's fine. And so this is a classic case of apathy. They just have no drive to do anything. They have no interest in certain activities. They just are content doing basically nothing. So we didn't talk about this specifically, but the treatment of choice for apathy are the cognitive medications. So you always want to start with the Aricept or Namenda or Exelon and Namenda. They're going to show the most benefit for apathy with the fewest amount of side effects. If those don't work, you can switch to something with a little more stimulation like Wellbutrin, or the last line is actually the stimulants. So you'll give a low dose of like Adderall or Ritalin, and that can also help with their severe apathy. I usually only do that whenever they're doing like absolutely nothing, though, because it can increase their agitation and cause psychosis. So you have to keep a very close eye on it if you use the stimulants. It's very safe physiologically, though. Very minor increases in blood pressure or heart rate, and they usually go back to normal. Okay, and last one, Agitated Agnes. So she is 85, living in a nursing home. You get a call during the night, and the staff say she is constantly agitated. She's aggressive. It doesn't matter what you do. She hits at you. Anything gets her riled up. I get this all the time whenever I go to a nursing home, and it's not because it's actually true, it's because they're overwhelmed. The nurses are completely exhausted. They are constantly dealing with this patient, and they do not feel like they have the ability to step back and see what's actually causing the agitation. So the first thing I will tell you to do is those non-pharmacologic interventions. I would want a behavioral log to see what exactly is the precipitating factor to start causing their agitation. Is it a certain time of day? Is it a certain event? Is she having upset stomach or something, or pain? You want to do that. Then if you've tried any type of non-pharmacologic intervention like redirection or environmental changes, has that worked or has it not? And then if you've tried any medication, has it worked or has it not? And so that's my first step here is what have we tried? What is exactly going on? So ask more questions. Please don't just jump to a drug immediately. Now, if you go through all of those questions and they basically do come out as saying she's paranoid, she's saying that we're trying to kill her, we won't let her go home, we're holding her hostage, and then she's being physically aggressive, yes, you would use an antipsychotic at that time. So you would start Risperdal at 0.25 because it's the most tolerated with the least amount of side effects, and then increase to 0.5 QHS if needed in 7 days. So give it time to work. And I know they're looking for a quick fix, but if you just keep increasing the dose and increasing the dose, you'll end up overshooting it, and the patient will get overly sedated and end up in the hospital. So please take your time whenever you're increasing these medicines. Go very slowly because their metabolisms don't work as good as they used to. Okay, so conclusions: dementia is common. Behavior disturbances are even more common when you have dementia. And non-pharmacologic interventions are best. Also, pulling in other people to help you is extremely beneficial. And then psychotropic medications can help, but you need to make sure that you're using the lowest doses possible and using the least extreme measures first with medications. Those are all my references. And hopefully you're not completely overwhelmed like this poor koala. And you have any questions, please let me know.